مساء الخير. The topic of this session is the renal amyloidosis. أنا مضطرية ابتدي معلش سوري عشان الوقت بيحسب عليا. فالتوبيك اللي هنتكلم عليه دلوقتي هو renal amyloidosis. Amyloidosis الحقيقة is a very classical topic، يعني لو قريتوه في الكتب all through the books مش هتلاقوا فرق كبير قوي، بس in the recent years حصل trends كتيرة قوي recent ones in terms of the investigation and the treatment. We'll go through it الحاجات البيزكس اللي كلنا المفروض نكون عارفينها وكمان ال recent trends بتاعة ال investigations with treatments. By definition, amyloidosis is a generic name that refers to the extracellular tissue deposition of fibrils. And I underline the word fibrils. I want you to concentrate on the word fibrils. It's very, very important. These fibrils are composed of low molecular weight subunits of a variety of proteins, many of which circulate as constituents of plasma. So we have two very important keywords here in the word amyloidosis. It's fibrils, and they are formed of proteins. Amyloid fibrils are insoluble proteins, as we said. The fibrillogenesis, or the formation of these fibrils, includes folding and unfolding of these precursor proteins. We'll see how folding and unfolding happens in the pathogenesis of amyloidosis. Fibril formation is also associated with co-deposition of non-fibrillar substances. يبقى احنا عندنا two very important keywords. عشان أعمل amyloidosis I need fibrils and non-fibrillar substances. These non-fibrillar substances mainly constitute many components. One of them is called serum amyloid P, or the SAP, and it's also very important to remember this word. It has very important prognostic, diagnostic issues that we're going to discuss later. I want you to see here how the fibrils are formed. This is a normal partially unfolded fibril. And then these unfolding fibers, they become arranged in this array to form the amyloid fibrils. Lot of genetic elements determine how these unfold and they fold and they misfold and how they deposit. This is determined primarily by many genetic factors. These genetic factors, they are involved in the predisposition to develop amyloidosis. And this answers a very important question: why a person develops amyloidosis and another person does not develop amyloidosis. What the genetic elements here, what do they determine? They determine that some proteins are more prone to the fibrillogenesis, to form these fibrils that we've seen before. Second is that these disorders, not every chronic inflammation or any chronic disease results in amyloidosis. For example, diabetes, for example, systemic lupus. These both are chronic conditions, and they are concerned with a lot of chronic inflammatory cascades, but they do not develop amyloidosis. So the process itself, where these disorders, the chronic inflammation, determines the deposition of proteins, is also genetically determined. Hereditary disorders that affect the level of accumulation of these precursor proteins. What happens to the level of these proteins is also determined by genetic elements. And this is very evident in familial Mediterranean fever, for example. The most frequent types of amyloidosis we're going to deal with is the AL, the AA type, and some hereditary types of amyloidosis. Now let's speak about the renal amyloidosis, which is my topic today. Clinically evident renal amyloidosis, will be discussing AL and AA, and again the hereditary amyloidosis. I want you just to take care of something, that the beta-2 microglobulin that occurs in patients maintained on chronic hemodialysis actually is a type of amyloidosis, yes, but it does not primarily affect the kidneys. But we're also going to talk about it briefly later. The incidence of amyloidosis is about 2 to 12% of all nephrotic syndrome presentations. The clinical manifestations, they vary according to the predilection of the amyloid fibrils in the glomeruli or the vascular or the interstitium or wherever they are. So we have glomerular deposits. These glomerular deposits present predominantly by proteinuria and nephrotic syndrome, characteristically with a bland urinary sediment and normal serum creatinine. In these, end-stage renal disease develops in approximately 20% of patients. The vascular amyloid, the amyloid deposition is mainly in the vessels. It leads to the narrowing of these vessels. This patient will present with slowly progressive chronic kidney disease with no or little proteinuria. Less common is the heavy tubular deposition, where they become deposited in the tubular interstitial structures, leading to tubular manifestations or tubular dysfunction, like renal tubular acidosis, polyuria, or acquired Fanconi. Crescentic GN again can happen secondary to amyloid deposition. This is a very rare condition, and it's almost always associated with the type AA amyloidosis secondary to rheumatoid arthritis. So here we discussed all the presentations of amyloidosis, and we know now that it depends on the site of deposition of these fibrils. Diagnosis. As Dr. Tarek Fayed just said right now, of course, we all depend on renal biopsy to diagnose, and it all depends on the presence of hyaline material, which is by light microscopy evident. However, we all have to understand that there's a very poor correlation between these deposits and the degree of proteinuria. There's no correlation. These fibrils bind with Congo red, as you can see here. This is the Congo red appearance. And then under polarized microscopy, they will give this characteristic green apple birefringence. This is a very important slide. I want to stress on that one. Today, it's evident that we cannot diagnose any type of amyloidosis without first examining the type of predominant protein in these fibrils. As you can see here, this is called proteomic analysis of the amyloidotic tissue. And it gives evidence to the presence of AL or AA or whatever other kind of protein prominent in the amyloidotic tissue. So this is called proteomic analysis and becoming essential today in the diagnosis because, as you will see later, the treatment differs markedly between AL and AA amyloidosis. Immunostaining is also important. As you can see here, this is an anti-lambda and this is an anti-kappa. And this is also an anti-transthyretin. These are different proteins and different immunoglobulins that are present inside the amyloid deposits. And as you can see, the anti-lambda here is very evident with the negative results of the anti-transthyretin and the anti-kappa. So probably this is the immune fixation here happened to diagnose that this is an anti-lambda, that the prominent immunoglobulin here is a lambda chain. This is, again, it's not very clear here, but this is a negative staining for kappa light chains. And this is a positive staining immune fluorescence. There's also the iodine-labeled scintigraphy. And as I told you before, that the amyloid deposit is composed of two major components, the fibrillar component and the non-fibrillar component. This diagnostic tool depends on the non-fibrillar component, the SAP. This is actually a scintigraphy for the SAP. So it happens to localize where the amyloid tissue is predominant throughout the body. It's called the SAP scintigraphy. And finally, and most importantly, is the electron microscopy. It answers a lot of questions. The electron microscopy can tell you that these fibrils belong to amyloid deposits, and it also can tell you and determine the type and the site and the distribution of this protein. So it's very useful in this diagnosis. So renal amyloidosis, we'll be talking about AL, or the primary, secondary, and hereditary amyloidosis, and we'll also tackle some issues in the dialysis and transplantation issues. First, the AL amyloidosis. Of course, we all know that AL is secondary to immunoglobulin light chain amyloidosis, in which these fibrils are composed of the fragments of the monoclonal light chain. It's very important to recognize this. These patients, they might present with amyloidosis alone or in association with other dyscrasias like multiple myeloma or Waldenstrom's. As you can see here, the light chain, these parts of the immunoglobulin are the ones that are secreted excessively and are the ones that form the fibrils to form AL amyloidosis. This is the story I was telling you about the folding and unfolding. It's a major issue in amyloidosis. Here, this is the plasma cells. They are increasing in number, releasing immunoglobulins, increasing in number, releasing the light chains, the pink dots here. And these light chains undergo a process of misfolding. This is not the normal appearance of the light chains in the immunoglobulins. So this process of misfolding light chains happen to leave these residues of prefibrillar aggregates. These are the ones later on that deposit in the tissue, giving rise to all the manifestations that we know about AL. For example, the manifestations that cause microglossia, the periorbital purpura, or the characteristic raccoon eyes. They deposit in the renal tissue, they deposit in the soft tissue and in the heart as well. This is the organization of these prefibrillar aggregates. So it's all the story all begins with misfolding of these immunoglobulins, all the light chains immunoglobulins. The bone marrow biopsy, again, is very essential for the diagnosis, and we're going to follow the same cascade of immunostaining and protein analysis to reach a diagnosis. The treatment. It's very easy now to understand that the treatment of AL lies mainly in the eradicating the fibril precursor protein, because now we understand that the main problem is in these fibrils, so we're going to eradicate these fibrils by suppressing their production. Many issues here are being discussed. Primarily a combination of chemotherapy, melphalan and cyclophosphamide, the most famous in the treatment of AL amyloidosis. However, there's a very few and slow response to these two drugs, to the extent that they are now rather looked at as second lines of treatment. They also provide very poor survival, and the organ responses are not up to standards. So what's next? Immunomodulatory agents like the thalidomide and the cyclophosphamide, they show a good response. But however, the toxicity is very high. As you can see, how do they work? This is a malignant plasma cell. And this malignant plasma cell stimulates the macrophages. And there seems to be some interaction between the two. There is a common language. The plasma cells releases cytokines to stimulate this macrophage. And in turn, the macrophage releases vascular growth factors and release other cytokines to further stimulate the malignant plasma cells. And so the cascade goes on and on. So the whole point here is breaking this cycle. We break this cycle at two levels. The first level, the one that we're going to talk about these drugs, the lanidomide and the thalidomide. This is more recent. But what do these drugs do? They break the cycle. They stop this growth factors and interleukins and cytokines from reaching the malignant cells. And consequently, the growth of the malignant cell decreases, and consequently, they release less cytokines, and et cetera, et cetera. So this is one way to control the release of the immunoglobulins. Autologous stem cell transplantation is then together used with these chemotherapeutic agents, because we need to replace the very active bone marrow that releases plasma cells all the time. So we need to replace it with something normal. However, this is not a very practical issue. The autologous stem cell transplantation needs a lot of preparation that most patients are too tired to go through these processes. So usually the kind of patient that you go for this treatment is very narrow. So what do? There came a very important invention. It's called the bortezomib. I know you've heard about this before in the multiple myeloma treatment. It's now becoming very, very famous in the AL amyloidosis as well. It's a proteasome inhibitor-based regimen, and we'll see how that works. It's a very magical drug, as they say. The combination of bortezomib, cyclophosphamide, and dexamethasone has been recently introduced. What do? Again, remember this. Now we have the malignant plasma cells. We tackled this site before with the thalidomide. Now it's time to tackle the main nucleus of the macrophage, the nuclear factor kappa, because the nucleus here happens to produce all the cytokines and all the growth factors that further stimulate the plasma cells. That's what the bortezomib does. It stops the stimulation of these macrophages. So the cycle is broken. So together, bortezomib with some chemotherapy that kills the plasma cells, and this drug happens to stop the stimulation of this cellular interaction, that happens to lead to good rates of remission and good organ responses. Two new studies conclude that this novel therapy can lead to complete hematological response. It also allows patients to become eligible for autologous stem cell transplantation. It improves their condition so that they perform autologous stem cell transplantation. The high response rates and good tolerance have led bortezomib combinations to become front-line therapy in AL amyloidosis. Second issue here is the secondary amyloidosis. It's a totally different story, but again, we're going to be concerned with two main things, which are the fibrils, as we said before. You can't diagnose amyloidosis without the fibrils, and again, the non-fibrillar components. The definition does not change, no matter how the type of amyloidosis changes. AA amyloidosis, we all know that it complicates chronic diseases associated with inflammation or recurrent inflammations. It's associated with increased hepatocyte production of an acute phase reactant called the SAA. This is different from the SAP, which is normally present in plasma, but this is called the SAA, serum amyloid A protein. The stimulation is further enhanced by cytokine production. This is again the story. For example, we have a joint inflammation, rheumatoid arthritis, juvenile rheumatoid arthritis, or whatever the cause is. It can be other kinds of infection or even malignancy. This leads to pro-inflammatory cytokines. They stimulate the liver to release the soluble or the serum amyloid A protein. This serum amyloid A protein, which is an acute phase reactant, it goes the process of folding and unfolding again, just like the fibrils, to become deposited, giving rise to AA amyloidosis in different tissues, including the renal tissues. So the fibrils here are composed of fragments of acute phase reactant serum amyloid A. And so that's why they call it reactive amyloidosis. It often leads to end-stage renal failure in patients who have high levels of this serum amyloid A. There's a correlation. The higher the level, the more instance of developing end-stage renal disease. This is a list of the different inflammatory and infectious conditions that can lead to the release of serum amyloid A from the liver. As you can see, chronic inflammatory disease like rheumatoid arthritis, ankylosing spondylitis, the Behçet's, inflammatory bowel disease, these are the most famous. Also, we have tuberculosis and osteomyelitis, renal cell carcinoma, hepatoma, leukemias, Waldenstrom, a very wide array of diseases. Due to their chronicity, they stimulate the liver to release the serum amyloid A. Treatment. The major therapeutic strategy here in amyloid is the treatment of the primary inflammatory disease. And there's no wonder in that. We all know since the cause is the chronic inflammation, there's no way to control the serum amyloid A release from the liver except when we control the primary disease, which is the inflammation or the infection that has caused it initially. So intensive treatment that lowers the serum amyloid A levels, it does halt the disease progression, and in some cases it leads to complete renal recovery. What examples do we have here? Examples is the treatment of chronic inflammatory bowel disease after resection of the affected bowel. This leads to complete remission of the renal amyloidosis. Chronic arthritis, also treated with immune suppressants, happens to halt the disease progression in the renal tissue. Medications. The medications mainly used to concentrate on the following. As you can see, this is how it's done. The inflammation happens to release several cytokines, interleukin-6 being the most important, tumor necrosis factor alpha. These are the most important. They stimulate the liver releases the serum amyloid A, then amyloid A fibrils. This serum protein happens to go unfolding and then it deposits. So the whole key here is to stop this using anti-interleukin-6 drugs, anti-tumor necrosis factor drugs. This has been the initial rationale to treat the AA amyloidosis. Colchicine has long been used, and actually the mechanism of action of colchicine is not quite clear. However, there's a very important word in the mode of action. It's called a disaggregator. You know, it prevents the folding and the unfolding of the fibrillar proteins. So that's why it's a very useful drug in treating AA patients. The problem with the colchicine is that there is a lot of controversy whether you can use it in diseases causing amyloidosis other than FMF or not. The studies have been controversial. Some say it does work for other diseases causing amyloidosis like ankylosing spondylitis or inflammatory bowel disease. Others disagreed totally, and they proved only that it can be used in familial Mediterranean fever causing amyloid deposits only. Novel therapies. What do we have today to treat amyloidosis A? It's a drug called CPHPC. They still don't have a name for it. It's still under experimental trials. But the interesting thing about it is that it tackles the SAP. Do you remember the SAP? the serum amyloid protein that is normally present, the non-fibrillar component of the amyloidosis. That's why we stressed on it at the beginning that it's a very important issue to remember in terms of diagnosis and in terms of treatment of amyloidosis A. So the plasma glycoprotein serum amyloid component is a universal constituent of all types of amyloid plaques, and it potentiates the amyloidogenic process. This drug happens to cross-link the pairs of SAP, resulting in rapid clearance of SAP. That's the first step. The second step is the introduction of anti-SAP antibodies, which can now target the amyloid deposits. Now that there's no longer SAP in the plasma, it's free to target the amyloidogenic part of the SAP. So this drug happens to work on two steps. First of all is the rapid clearance of the SAP, and second is attacking by anti-SAP antibody. They attack the target organs where it is deposited. Another drug, which is called the eprodisate. The eprodisate is, has a structure similar to heparan sulfate, and I'll show you a diagram to tell you the importance of heparan sulfate. Heparan sulfate is a stabilizer of the protein structure, as you can see here. This is the heparan sulfate. It stabilizes the protein structure. So this drug, eprodisate, happens to work by competitive inhibition of the heparan sulfate, leading to breakdown of these fibrils and again destabilization of the fibrillar components of AA amyloidosis. In a study, eprodisate was assessed to evaluate the efficacy and safety in patients with AA amyloidosis. It was clear that it could arrest the decline in renal function. Nevertheless, it had no effect on protein excretion. So it happened to work rather on a cellular level rather than on clinical to prevent the proteinuria in these patients. The conclusion that was eprodisate can slow renal dysfunction. However, the glomerular damage previously incurred in the kidney was not affected. This means that what happened has happened. It prevents further accumulation of AA amyloidosis, but it does not happen to improve previously deposited AA fibrils. The results of this study will be complete by May 2014, God willing. So now we move on to the third type of renal amyloidosis, which is the hereditary amyloidosis. Hereditary amyloidosis is rare. Mutations in a number of proteins can result in relatively selective renal deposition. Of course, the most common of these, we talk about the transthyretin. It's the commonest. And I'll move on to the treatment. I'm sure we all know that the only treatment available for hereditary amyloidosis is the liver transplantation, because it happens to improve the whole problem from the beginning. Liver transplantation is, can better be done while the disease has just been discovered during the first year. What are the novel therapies? Tafamidis is a novel therapy for the hereditary amyloidosis. It acts by binding to the protein itself, the transthyretin. And it prevents the dissociation, again, without going through a lot of details, it prevents the folding and unfolding of these fibrils. This is a diagram showing the transthyretin. This is the transthyretin molecule. This is normally what happens. This happens, the transthyretin molecule happens to divide. This is a genetic mutation that happens, and it divides, leading to the formation of folded monomer. These folded monomer then become misfolded, and then they go certain transformational changes, giving at last the fibril that deposits, giving rise to hereditary amyloidosis. In this case, this drug, it happens to stabilize, this is the action of the drug, it stabilizes the transthyretin molecule, so it does not divide, and the whole cascade is stopped. Clinical trials indicate that tafamidis slows the disease progression, demonstrating improvement in some hereditary amyloidosis. This drug has been tested in several hereditary amyloidosis, mainly those affecting the neurological types of amyloidosis. Trials in renal amyloidosis are still underway. Now we've discussed the AL, the AA amyloidosis, the hereditary. There are some dialysis and transplantation issues that we need to tackle before we close up. Hemodialysis and chronic ambulatory peritoneal dialysis, of course, are equally effective, with the limiting factors that the former happens to have hypotension as a main complication and the later infection and peritonitis. The prognosis for those who require dialysis is usually very poor. The dialysis-related amyloidosis is due to deposition of beta-2 microglobulin, which usually accumulates as the patient spends a lot of years on dialysis or hemodialysis therapy. And again, I would like to stress that this disease mainly manifests as an osteoarticular disease and not a renal disease, although it is dialysis related. The experience with renal transplantation and renal amyloidosis is mostly limited to AA amyloidosis. AL amyloidosis, these patients die very early, and we don't have a lot of experience with their transplantation. The largest study of renal transplantation showed that the 3-year graft survival was similar between those patients and other patients undergoing transplantation for other different reasons. However, the patient survival was lower in AA amyloidosis due to repeated infections and prominent cardiovascular disease. Recurrent in amyloidosis, the position in the transplant or in the graft is about 20% of cases. However, graft loss due to recurrence is uncommon, again perhaps because the patient survival himself is very low. In familial Mediterranean fever, colchicine is given in a dose of 1.5 to 2 milligrams per day, and it can prevent the presence or the recurrence of proteinuria in these patients, taken as a marker of recurrence of disease, the proteinuria here. Autologous stem cell transplantation can be performed in AL patients. Kidney transplantation can be considered once hematologic complete response is achieved. Actually, there's a very big debate in many researches whether to start first with autologous stem cell transplantation or renal transplantation. Some people prefer to start with renal transplantation. This gives a better outcome with autologous stem cell transplantation, knowing that the patient will be more healthy and more able to sustain the immune suppressive therapy. But this debate has not been settled yet. The diagnosis of renal, this is the take-home message. I have 2 more slides to go. The take-home message is that the diagnosis of renal amyloidosis must include a biopsy tissue with immune histology and protein identification. Proteinuria and protein electrophoresis are not adequate. AL amyloidosis, very briefly, bortezomib and autologous stem cell transplantation are first-line therapy nowadays. AA amyloidosis, you treat the underlying disease, and then you can adopt one of the 2 recent drugs that tackle the SAP. The transthyretin amyloidosis, you can use liver transplantation. Whether you have to use the novel therapies to stabilize the transthyretin in renal disease or not, it has not been settled yet. So now during our talk, we talked about AL, AA, hereditary, and dialysis and transplantation issue. Thank you very much.